Welcome back to Blame Anesthesia podcast. I'm Melissa.
I'm Stephanie.
I'm Andy.
I'm Jimmy.
Let's do a cheers.
All right, cheers.
That's how we started, baby. It's a late night special.
All right, we're going to talk about different inductions. Somebody wanted to hear about the art of induction. I don't know, bro. Just you look at the patient and you figure it out. Everybody's different, so it's something that comes with experience. I don't know.
Yeah, you don't do cookie cutter anesthesia.
Yeah, every patient gets a completely different induction, and sometimes they're better than others. But we can talk about different inductions for like different cases.
Sure.
So, for example, like hearts, I think there's a different induction for somebody that is hypertensive with like diastolic heart failure versus someone with systolic heart failure. Like if someone's EF's 25%, I'm going to use etomidate all day. But if someone's EF is 70%, but they have diastolic heart failure, I'm going to probably use some propofol because their blood pressure is 200. So
True. Can I ask you a question though?
What's up?
So cardiac. So do you guys ever just solely do like benzos and narcs?
So
as
how
just,
I was trained was what we would draw up 20 cc's of fentanyl, we draw up 10 of Versed, and we draw up like 20 of Vec. And that's old school cardiac induction. It's like narcs and benzos, and then paralytic. But where I'm at now, it's more of a standardized induction a little bit. I will say, so the flow of doing a heart, I give less narcotic on induction specifically because I have to scrub in, well, not scrub in, but I have to get sterile to do the central line. And I've found that patients start becoming hypotensive if I give a lot of narcotics while they're on gas right after I intubate and I'm doing the central line. So one induction I've kind of been doing is maybe 50-ish of fentanyl, 20 of etomidate, lidocaine, and rock. And then once they're intubated and I get the line in, then I'll start working in fentanyl. Like, whereas other hearts, it's completely different. Like I used to give 200 of fentanyl, 6 of Versed, and then Vec.
And then you notice that they get very hypotensive because you're not stimulating
because
them.
You're not stimulating them. The gas is
Gas.
starting to come on, and then the fentanyl is starting to come on. So you're having to like treat blood pressures, but you're like directing your circulator, like, hey, push 1 cc of this, like to help you out because you have no hands because you're putting in a central line, whatever. So that was an old CRNA, or an older cardiac CRNA gave me that tip, like give little to no fentanyl until the line's in, and that's made my life so much easier.
So if you're inducing a cardiac patient and you're not going to intubate, so you're doing LMA, and you want to use etomidate because their EF is bad.
Yeah.
We're talking about that.
So specifically, like say you're doing a pacemaker and or an AICD and the patient's EF's 15%, I hate putting in LMAs with etomidate. They get such bad myoclonus. They need 1 to 2 cc's of prop just to loosen them up because they don't open their mouths. So you're stuck bagging them with gas after you induce just to like loosen them up. So I like to do like a 75% etomidate, 25% propofol kind of ratio if their EF is like 25 to 30. But I'm sure there's people that don't like that at all. I don't know. I just can't get the fucking LMA in, or they spasm, or they're still breathing. Like etomidate won't completely knock out their drive.
Yeah.
What do you think?
No, 100%.
I've been talking too much.
Like exactly what you were saying was like, it's very patient specific. You don't
Goddamn
just
dog.
You don't just all the time push etomidate or all the time push propofol. You have to look at your patient and make sure that
I love propidate. Propidate's like my favorite drug.
Yeah, I'm either propofol or etomidate. I don't really like. I don't know why.
I sometimes mix it, but
Well, I don't mix it, but I don't. Some people mix it
together in one syringe.
Oh, do you really?
Yeah, I sometimes do it.
But you do like
50-50?
But if I have an EF of 20, I'm just gonna do straight up etomidate.
Yeah, I mean that's probably
That's like TEs, general cases, like
yeah. If I'm doing
etomidate.
TEs or something, I'll do straight etomidate. But I've just found I
don't know.
can't get
You
people's
just,
mouths
you
open.
just figure out the patient. You just have to look at their history, and then at the moment you'll make that decision.
It's a little
I don't know.
intuition too. Like you can,
Yes.
because they can look like one thing on paper, and then you
Yes.
see them, and
You're
you're
like,
like, I gotta
You're
do
like,
something
they
different.
look really
Yeah.
bad.
Yeah, like they can look way different, like
Right.
in the
The
chart
other thing
versus
though,
person.
so you give more fentanyl if you're doing a straight etomidate, LMA, for example. Like I wasn't doing this, but a more seasoned CRNA told me, if you're putting in an LMA with straight etomidate, give 100 of fentanyl. And I was like, I like to get them breathing immediately, so I usually give like 25 to 50 of fentanyl, and then I work it in once they start breathing. But if you're doing straight etomidate and you can't get their mouth open, sometimes that 100 of fentanyl just loosens them up a little bit more too. If you don't want to use propofol, but I think it's just some trial and error.
That's a cool thing with the etomidate. I feel like their blood pressure never drops.
Yeah.
But sometimes it
goes
like,
up.
Yeah, it goes up.
Yeah.
You almost have to be careful.
But it's better
yes.
up than low,
Yeah,
honestly.
yeah.
So that's kind of what I've found. If their blood pressure is 190 and you give straight etomidate and you give and you try to put LMA in or whatever, and you can't open their mouth, they get hypertensive. So if you give like 2 cc's of prop or like 3 cc's of prop, sometimes it's enough just so they don't have that huge spike, but they don't drop a ton. I don't know. And I think the biggest thing is just fucking go slow. Like you don't have to slam everything in. Like you can do a safe induction with propofol if you take your time.
And you push slow.
Yeah.
And I think too, looking at your patient is actually really important, what you guys were talking about. So yeah, say if their blood pressure is 150, but then they're like on levo and vasopressin, like I don't think pushing propofol is a good idea. You know
Yeah,
what I'm
if
saying?
you-
These are very septic patients and whatnot.
That
So
are
maybe
running on
even
pure
go
SVR.
exactly.
So
So
you
I think it's
dilate 'em out.
exactly. So I think going with the etomidate is probably the better choice. That's just me. You know, use a lot of critical thinking. Don't just look at the ventilator and be like, or the monitor and just push propofol because you're like, oh, they have a high blood pressure. So
Yeah. But I mean, another thing, like if someone's healthy, but their blood pressure's borderline, like if their heart's fine and they're 90 over 50, I'll use prop, but I'll push like 200 to 300 of phenylephrine with it just to keep it up.
yeah, same. And then in you know, like you were saying, I do neuro. With my neuro patients with TIVA and whatnot, I do notice that I try to actually get away from pushing fentanyl, and I started noticing so what people like to do, or what I used to like to do, is patient gets on the bed, I hook them up, start giving them some oxygen, push fentanyl, 50 of fentanyl, push my lidocaine, push my prop. I notice, to me, my opinion, the fentanyl is not really gonna help much. I think it kind of hurts me in the sense of like how you're saying, you induce, you put them to sleep.
There's
And
no
then
stimulation.
There's no stimulation.
Yeah.
I have him on gas. I have my neuro monitor tech. He's out there. He's putting in his, his lines
One by one.
one by
Take his
one.
time.
Yeah.
Mind you, side note, when they take it out, the patient's fucking bleeding everywhere. And I look at him, I'm like, bro, fix that. But yeah, so I started to actually push fentanyl just actually a lot earlier too. And I give them like 25. And I notice, like, say if I don't want their blood pressure to shoot up during induction, I give it when they're on the bed, or like in pre-op a little bit. I'll give them like 50. And I notice actually their blood pressure with propofol and a nice slow push of propofol, they're actually pretty stable. They get this nice like flow, and then sometimes you have to kind of bump them up because they're still not being stimulated and whatnot. But with neuro, you
think
don't
that's
want them to shoot up in their
I
blood
think that's
pressure,
another
so-
thing is just knowing like your OR. Like
True.
if you have surgeons that take their fucking time and don't come in the room for 45 minutes, or your circulator's talking shit instead of prepping, then like that's like gonna screw you over because now you're having to press a patient for 45 minutes before they make incision. So those are the times I'm gonna give 50 of fentanyl. If somebody comes in and they're cutting, like some of our fast robot guys that are, incisions within 10 minutes of you intubating, yeah, maybe just push 100 of fentanyl on induction. It's like, it's kind of learning like your flow. In
How long the
school,
case is, how short the case is, how fast the case. If you're doing a lap epi, you know you're gonna be done in like an hour.
yeah, like in
Depends on the surgeon.
Depends on
yeah,
It does, though.
Gotta know your surgeon.
Gotta know your
maybe
surgeon.
at your hospital.
Right.
No, I've actually seen lap epis that take 2 hours.
All right, I'm gonna open my
A
beer.
little too much.
Let's watch this right here with the Miller. So yeah,
Oh, you fancy.
he's fancy.
Miller boys.
Miller boy. He's struggling. Oh,
Oh, I was gonna be like, I think you need a Mac.
shots fired.
Another good use for a Miller blade.
So when you're doing your TVAs, what do you normally start? I know it depends on the patient, but what do you, if you're not running Remy, what will you run your propofol at? Will you
So-
run it higher?
So actually, I don't run Remy. Personally, I think
I don't
the only
either.
time I use Remy, I've done with like carotids. I do Remy. Personally, please don't judge.
We're judging.
We
We're
listen,
judging.
we don't judge.
Yes, and with Remy, it's a lot of for the case. I'm more for the patient, if that makes any sense. Like when they're waking up, I want to make sure that towards the end I can monitor their pressure. I don't know. I like to be very hands-on with my neuro patients. So what I normally do is I'll give them 50 of fentanyl sometimes on induction if they can handle it. Propofol, lidocaine. And while I give them that nice bolus and I get them nice and comfortable, I fill up that compartment, I will start my Tiva, which is just propofol. I kind of keep it simple. I used to be all fancy. I used to do lidocaine drip, Presidex, all that stuff. And I
Lidocaine
spoke
drip,
to
ketamine drip,
yeah, I used to do a lot of
Presidex
that.
drip?
Yeah, and then
remifentanil drip,
I met a
fentanyl drip.
A couple of grams of mag.
I used to
Yeah.
do
I do that a lot.
mag.
Oh
Yeah.
yeah. Oh,
Oh, I
some
love Mac.
circulators know I love it, and I forget to get it all the time. They're pissed off at me because I forget to get it. Oops.
The best though.
I'm sure, like,
we
if
have
they're watching, like, they know who they are.
we have just 1 gram vials.
Vials
I
of
know.
mag?
We
No,
have,
we have the,
Like
the
in our
bags.
we do too, but like in the heart room, there's just in the Pyxis,
Oh,
there's just like
okay.
max. We'll just push 2 grams. Like before we come off pump, we'll
Yeah.
just push 2 grams.
Yeah.
And I think it's in a lot of our other Pyxis.
Yeah, we actually requested to have magnesium in our neuro room, so it's pretty cool. So we just have it there.
Yeah.
So with my Tiva, it's just propofol, but I do push dilaudid, so it kind of gives you that that I know they're probably not going to move, and I give them some fentanyl here and there, and I'm not. I would say about 90%.
I'm a bitch. I would still use Remy. I don't care. And then
Yeah,
I'll work
it's-
Narcs in
So-
at the end.
I do the same. I use dilaudid up front, like 1 milligram up front, beginning of the case of a spine case, for
Yes.
example, right? Because it's going to be like maybe an hour, 2 hours, depending on the surgeon too. 'Cause
I don't
I've
know
been with a
anything because I don't do
no?
neuro.
I've been with a surgeon that does it really fast. She works pretty quick, but I worked that in already. Remifentanil, fast on, like fast on and fast off, right? So then you have to okay, now start catching up if you're near the end. Okay,
Yeah.
let's start working in that fentanyl or dilaudid or whatever. But I do it in the beginning already. Like start treating.
That's what I think we would
start-
do. Like I did a lot of neuro at one facility in school, and what I thought was kind of cool was before we would start going to sleep, we started the drips.
Yes.
So before we would even induce, we would just have them going. They wouldn't be deep enough yet, obviously, by the time you get them in there, but we would induce, and then it's still kind of like already on board. But we would still give fentanyl throughout the case. Remy was more
I feel like,
Like
it's
so
just
they
a
don't
safety
move.
it's not.
net.
Yeah, it's not.
It's a
not-
safety net.
Not a paralytic, but it just kind of it made it to where they're not going to move throughout the case. So since you
Comfortable.
can't give a paralytic, all right, Remy's going to keep them still. But yeah, then I would work in narcs at the end of the case. I'm way too scared to do what you guys do,
So I
which is
think-
just
So
like
I- as
push
a-
narcs throughout the case. I would be like, fuck, I'm gonna have to Narcan them.
So
Oh,
yeah, it
Narcan never hurt
depends.
anybody.
I've had to
I-
Narcan 2 people, and I'm so ashamed of
Oh,
myself.
shit. I had it, me too, in my career right now.
Yeah.
Only twice.
Wow.
I know.
Me, I'm like
because I try
8,
to be careful
9,
with it
10.
too. No,
It's
I
because
try
you're
to be
just
careful.
pushing Dilaudid on grandma.
But guess what? Grandma's gonna be like waking up
Comfortable.
comfy.
But it depends because as a student, I saw a CRNA do that. She was like, I'm not used to remifentanil. I'm just gonna work it in already. And I was like, oh, this is different because I was so used to. It's like kind of cookie cutter. Like you want to do sufentanil, remifentanil, okay, but there's other ways to do the exact same thing, and you still get the same result.
Yeah. I'm not saying it's wrong. I'm saying
there's so many ways to do
I'm
it.
just like not as experienced in neuro.
I just don't want to have to waste another drip.
That's and that's
I know
another
we have
That's
to
another thing.
waste. everything.
Well, one
I
day you should
fucking
try it.
hate that.
Yeah, we're at a facility that you have to waste propofol, ephedrine.
that's
Same.
It's all
bullshit.
controlled.
Same.
Yeah.
Everybody knows what facility that is.
Yeah, when we
probably.
were at our
there's
peds
only
rotation,
one.
when we were at our peds rotation, there was literally propofol everywhere. You open up a drawer, just like in a desk, and there's propofol in it. It's just everywhere.
Yeah, they had the 50.
You find it behind the garbage can. You're like, oh, I got it.
Bro, when we were doing peds, they had the 50 ml bottles of propofol, and like
yeah.
they would put us in endo, and we would just like have 20 GI cases that you're doing. You run peds at like 300, bro.
Yeah.
So you're just like filling up. So we would just have like 10 60C syringes ready to go.
Yeah.
Just to fly through. But here that would be okay.
Illegal.
Yeah.
Yeah.
Stop using propofol, anesthesia people. You're ruining our lives. Like, stop, dude.
Start using etomidate.
No, not stop recreationally using propofol. Like,
Stop
two,
putting LMAs in
Propofol is
yourself
a
and
good-
stop using propofol.
Yeah.
Propofol
Three
is so
idiots.
good.
Michael
I was
Jackson.
about to say that Michael Jackson drug.
3 idiots like mess around with propofol. Now I gotta waste this shit every day, bro. I
Yes.
hate you.
Yes.
That's all I got.
You know what I hate when when like I'm giving PACU report and I'll say like I gave whatever fentanyl. If the patient's already starting to wake up and they're like, I got fentanyl, I'm like, it's fine. Like,
I'm like, you're breathing.
Yeah,
Are you
you're gonna be
alive?
No,
okay.
it's even worse when they freak out. I got propofol, the Michael Jackson drug.
No,
Or
but
in
now
pre-op, what medication you use? Propofol, the Michael Jackson drug.
everybody is so scared of fentanyl because it's killing everybody, like
The whole
in
opioid.
street drugs. So they hear fentanyl and they're like, I'm like, yo, I went to school. I have a doctorate degree in
Exactly.
giving fentanyl.
Exactly.
All right.
You're like, you're fine.
You're
okay?
fine,
You're
bro.
fine.
Like,
Talking
I'm
about
professional.
So you're giving me drugs from the streets.
Listen, so talking about waking up. So the other day I had this young teenage, maybe 13, 14-year-old that I extubated him. And once I extubated him, I was like, fuck. And the nurse was like, wait, what's wrong? And I was like, yeah, I just pulled off this kid's mustache that's been working for 3 years hard to grow this thing. And I felt so bad. So I cut the tape and I went to go see his parents, and I'm like, tell him I'm so sorry. I handed him hopefully he could
mustache
just
back.
put it back on.
I think to put it in his belongings bag, send it home with him.
That's what.
This is yours.
So another thing.
And I was like, damn, never again. Now I'm gonna put like gauze over it, and I'm
I
gonna
mean,
put
I've
tape.
ripped off eyebrows with the
But
blue
always
with the blue goggles.
eyelashes.
Yeah.
Oh, but then you have the
feel
women
so
that have their
bad.
false eyelashes. You need to
I
be
think
extra
that's-
careful because that's money.
That's
That is
when
money.
you know
You can't do
you're
that.
like kind of dope is when you look at somebody and you're like, oh, let's save these lashes.
Yeah,
That means
know?
you really care.
Yeah,
Yeah.
you're like, that's the best part of this anesthetic is that I didn't rip your eyelashes out.
But you know, now you see
Because I've
girls.
I've pulled tape off one time and like every
no.
other hair it ripped out. So she just had like fucking.
I'll be like,
it
give me
looked
the
like
Dermabond.
she had like punk rock eyelashes, dude. They were like she had like sticking out. I don't know.
Yeah, but you know,
those blue goggles that we use.
I don't use them at all.
I stopped using
because
them.
it's so sticky.
Not even
No,
that.
oh, they're
They've-
so sticky.
But they've like left marks on
Bruising.
people's faces.
Yes, it
I
can.
don't-
It can. It's true.
All right, boom, new topic. Gotta add sound effects.
Hell
All right,
yeah.
so
Bing, bop, boom, bop, bam.
someone asked how to navigate OR personalities, like different OR personalities.
Fucking
And
raise
this,
your drips.
This happens, yeah. So you could choose to just ignore everybody and not talk to anybody, which that's not my style.
That's my style.
No, it's not. You fucking never shut up.
Oh,
Yeah, it's not your style at all. He talks to everybody all the time. But
That's my style. Once the drape goes up, that's it.
well, the drape doesn't have to go that up for you. It's just
yeah,
They-
once the
Wow.
they
drape
pass it to her, and it's
What?
like she's like.
once the drape lays over the face.
I put the drape really high up.
I was
She
just
gets
talking
on a
because you're
step
high.
So
and puts it up as
high.
high as she can.
She gets on her
I
fucking
do.
chair, and she's like,
Yeah.
"All right."
It's kind of hard. That's just like how to, I don't know. It's just being a person.
That's like life in general.
It's just life.
You learn that, I feel like, throughout clinical, like before you even become a CRNA, because you deal with so many preceptors and you're in the OR so much.
I
And
think-
even being a nurse, you dealt with it.
I think we kind of brushed on it like on a different episode. Find your balls, but also don't be an asshole and don't be like try to fly under the radar. But
Well, you're talking as an SRNA or as a CRNA?
no, like as a CRNA,
Like,
I
be
feel like
the
you-
balls, don't be the asshole.
yeah. Find your balls, don't be the asshole.
But you know, it's
Put it on a shirt.
That's,
yes, put it on a shirt. That's a good one.
That's poetry.
Wow,
No, but like for example, there's some surgeons obviously that are difficult.
Don't disrespect me. That's me.
Yeah, as long as you go in, like my whole thing is to be proactive, not reactive. True. So if a surgeon's an asshole, and I know he's an asshole, I will be like, what do you want from me?
True.
Where do you want your blood pressure? If it's like a certain blood pressure case or like a cardiac case or vascular or some shit, what antibiotics do you want? If you're doing, for example, I did a vascular case yesterday that I've never done before. I said, how often do you want your ACTs? Where do you want them? What's your blood pressure preference? So get all that shit out in the beginning of the case. That way you don't have to talk to them, because he was doing a case that isn't it's like newer for him. It's a bigger case. Yeah. I mean, I guess I can probably talk about, it's like a total reconstruction. It's like an EVAR, but he was doing all the branches. So it's called like a TAMB. I don't know. But the surgeons were obviously, it was two surgeons collaborating. They were like a little stressed out. So like the less you have to talk to them, the better their mood's going to be. So you kind of have to know, all right, I'm not going to be bullshitting and joking with them throughout this case. My job is to like keep the patient stable and shut the fuck up and like just get this done as quick as possible. But if it's a surgeon that is always joking around and you're doing a routine case that he does all the time, it's kind of nice to have a little rapport with these people. So you just have to feel it out.
That is true.
I mean, I don't know. That's probably what you guys think too.
That's why I like too, if you do the same room over and over. Like I've been in robots a lot lately, so I'm just close with that team. So like I know if it's a hysterectomy or something, we can go ahead and position them before and I'll intubate with the glide scope, just 'cause it makes everyone's life easier. So like if you can help them out too,
yeah,
I don't know.
But at the same time, if you're worried about it, like for example, she does that because she's comfortable. I am like, I don't give a fuck what you want from me until my airway's secure. I'm not gonna be in a bad spot if I get into a difficult airway kind of thing. But you make that judgment based on like your assessment.
Yeah, 100%. It has to be like, well, that's why like you trust your team. So you know if like, oh, we got to move this patient up real fast, we can just do it.
But I've been to some places where the circulator's like, we're going to have to pull them down. And I'm like, well, I don't give a fuck. I'm getting my tube in.
One too many times because I'm short.
Yeah.
That's a joke in the OR. Oh, she's short. She wants the patient up all the way up to her.
Yeah, but they'll talk shit, but they don't
talk
have
shit, but I'm like, patient safety.
Not even that. They have
not even
nothing.
Anyone who's going to be doing airway.
But that's your responsibility.
Exactly. And they don't understand that. Oh, my back. Get someone else.
Yeah. When stuff goes bad, they just
get
tap
someone
out.
else. Yeah. You can't move the patient because the patient is like up here.
So that's what I mean. Like find your balls a little. Like you have to put your foot down when you need to put your foot down, but also little things like let it slide if it's safe.
Yeah, and it is true. It's your responsibility. This person comes into surgery and they always say, "Oh my God, you're the one who's giving my anesthesia. You're the one who's going to be taking care of me." And they know you are keeping them alive, as corny as that sounds. And that's your responsibility. Your responsibility is this person. And it's everyone's responsibility in the OR. But ultimately, it's your responsibility.
Yeah, when shit
you
goes
keep
south,
them alive. Exactly.
When
everybody
shit goes south,
goes like
everybody
this.
looks to you. What are you gonna do?
What the fuck are you gonna do? You're the head of the bed.
So you are the capiton. They disrespect you until they need you.
Until they need you.
Yeah.
So you're the capiton of surgery. You know, surgeon fucks up. They look at you. You have to be the calmest person, level-headed, and you have to fucking show how badass of an anesthesia provider you are. And that's when people start respecting you. Yeah. One thing one of my professors said is, up here, you're calm. On the bottom, you're like a duck. Your feet are, flapping away. You could be nervous. It's okay to be nervous, but you don't let anyone see that you're nervous. Because if you're nervous... Yeah. Everybody's fucking nervous, but
so
if you're chill,
dude.
Exactly.
That was the silliest comparison I've ever
heard. Yeah, a duck.
Yeah, they said you.
Are you sure that's
duck.
what he said?
Yeah, he says, above water.
My professor called me goose, but he never told me to be a duck.
Yeah,
that's a type of duck.
Yeah,
a goose ain't a duck. Well, on that, let's end this episode. Thanks for watching. Subscribe to our YouTube.
Yeah, leave us a comment of anything you want to hear us talk about.
And
all we're talking about are comments because we don't really do we don't do.
You guys are coming in clutch. Yeah. Thank you.
All these episodes are you guys.
Hopefully we answered your question.
Yeah.
All right.
All
We'll
right.
see you guys next time.
Bye, guys. Thank you.